Hi, I'm Lindsay Bennett, Healthcare Executive. In today's video, I'm going to show you some revenue cycle KPIs or key performance indicators. I'm going to show you what they are, how to calculate them, what the formulas are, what the common data sources are to get the numbers that you need in order to calculate them, as well as how to interpret them. 18 revenue cycle KPIs that healthcare leaders should know. If you stick around until the end of this video, I'm going to tell you how to get these slides for free with the formulas and the definitions. Number 1, schedule utilization rate. This is the percentage of available appointment slots that are filled, and we can calculate this by taking the number of filled slots divided by the number of available slots. And anytime you want to express a number as a percentage, you can take that result and multiply it by 100. Some data sources for this are the EMR and practice management system. It might be from the scheduling module. You might have reports. Those are some of the possible data sources. When interpreting the schedule utilization rate, a low rate can tell us that we are not marketing effectively. It can be because we have a demand forecasting issue. Maybe the practice's hours don't really match patient demand and their needs. It can be due to a high number of no-shows, or maybe we're not optimizing appointment reminders, which is causing more no-shows. It could also be that we need to be in network with more insurance plans. If we have a high schedule utilization rate, it can indicate capacity constraints. So there might be a need to add an additional provider or an additional location. Number 2, eligibility verifications rate. This is the percentage of scheduled patients with their insurance verified prior to the time of service. And we can calculate this by taking the number of eligibility checks that are completed divided by the number of scheduled visits for the same time period. And again, to express that as a percentage, you're just going to multiply it by 100. Some data sources for this could be the clearinghouse. It could be payer portals, or it could be the EMR. And when we're interpreting the eligibility verifications rate, this is important because it is a root cause of denials, such as denials for not having insurance coverage in effect on the date of service. And that's why we need to verify and re-verify benefits 24 to 72 hours before service. A benchmark for this metric is better than 95%. Number 3, authorizations rate. This is the percentage of required authorizations that are obtained prior to providing the service. And the formula for this is the number of auths obtained prior to service divided by the number of services requiring an authorization. Remember, too, that not every payer requires an authorization and not every service requires an authorization. Some potential data sources are clearinghouses, EMRs, and payer portals. No authorization is a major source of denials and write-offs. So low authorization rates can signal front-end workflow breakdowns, and a possible benchmark is greater than 95% authorized prior to the time of service. Number 4, authorization turnaround time. This is the average number of days from an authorization request submission to the time that the payer makes a decision, whether they approve it or deny it. The formula is the average of the number of days between the authorization decision date and the authorization request date. So it's the authorization decision date minus the authorization request date. The potential data sources are utilization management and prior authorization platforms, payer portals, and logs. Long turnaround times will delay medically necessary care, and they can also impact scheduling. Another thing that's worth noting is that there is legislation that is out there right now. I'm recording this in 2026, and we are moving towards payers having to publish their turnaround time publicly. Number 5, pre-registration rate. This is the percentage of scheduled patients who complete required information prior to the time of service. Now, note that there is a lot of required information. There are things like consents, there's demographic information, there's insurance plan information, and financial information that they need to provide. The formula is the number of patients pre-registered divided by the number of scheduled patients. And the potential data sources for this are the EMR practice management system and also possibly digital intake tools. Low pre-registration rates can increase wait times and cause bottlenecks because all of those pieces of information, if they are not pre-registered, then they are having to provide that at the time of service, and that can increase wait time. Also, when they have to be done at the time of service, it can increase the likelihood of registration errors. And when we have higher pre-registration rates, what that does is it enables us to verify benefits. It triggers authorization workflows, and it also gives us visibility into what patients owe, which can help us increase point of service collections. Number 6, point of service collections rate. This is the percentage of estimated patient responsibility balances that are collected by the time of service. That could be due to pre-collecting or collecting at the time of service. The formula for this is the point of service collections divided by the estimated patient responsibility that's due at that time. The data sources for this can be estimation tools. It could be the EMR system. And higher percentages of point of service collections will reduce your bad debt significantly. That is because the probability of collecting from a patient declines as time progresses. So the sooner we can collect up front, the less bad debt we're going to have. And declining or lower point of service collections rates can signal the need to train staff in identifying patient balances and how to ask for payment upfront, scripting, for example. And it can also help us to identify if there's an issue with estimation tools or procedures. Number 7, front-end denials rate. This is the percentage of submitted claims denied for controllable front-end type reasons. This is things like intake and eligibility errors. The formula for this is the number of claims denied for front-end reasons divided by the number of total claims submitted for the same time period. And we would take this times 100 to express it as a percentage. Note that as with any kind of denials rate, you can also calculate this off of charges. So we could take the total claim dollars denied for front-end reasons and divide it by the total dollars of claims submitted. So it can be the claim count or it can be the dollars. The data sources for this can be the clearinghouse, payer electronic remittance advice data, or the EMR system. Higher front-end denial rates represent revenue leakage due to ineffective front-end processes or training needs. Number 8, registration accuracy rate. This is the percentage of patient records with no demographic or insurance errors at the time of entry. So they entered it correctly the first time. The formula for this is the number of error-free registrations divided by the number of total registrations for the same time period. The potential data sources are the EMR, denial reason codes. So if we have a denial for registration accuracy reasons, and internal quality audits. Interpretation. Errors in registration accuracy ultimately will drive denials. So what we want to do is we want to segment by the error type so that we can focus our training efforts. So I'll give you an example. Maybe when we are registering patients, we're not sequencing the insurances correctly when they have multiple insurances. That's called coordination of benefits. So if we're getting those types of denials, we might want to educate our staff on that. Or it might be that we are not capturing some key information and we need to remind people. But a potential benchmark for that would be greater than 97% accuracy. Number 9, coding denial rate. This is the percentage of submitted claims that are denied for coding-related reasons. Some examples of that would be that they have an invalid or outdated code, or it's missing modifiers. So the formula for this is the number of claims that are denied for coding-related reasons divided by the number of total claims submitted for the same time period. You can also calculate this off of dollars, like with any type of denials. So it could be the total dollars for claims denied for coding-related reasons divided by the total dollars of claims submitted. The data sources for this can be the clearinghouse, the ERAs, or the EMR. And a higher coding denial rate represents revenue leakage, and it can indicate a need for training. An example of this is that hospitals will usually have professional coders, and many physician practices will have different physicians or nurse practitioners who are doing their own coding. So maybe we have somebody using an outdated code and they just need some coding education. So that might be something that we interpret from this denial rate. Number 10, coding lag time. This is the average time in days between when a provider completes their documentation and when the coding is completed. So it is the average of all the dates coded minus all the dates that documentation is completed. So for every record, we are going to take the date coded minus the date the documentation was complete, and then we are going to average that result. The data source for this is typically the EMR. And what coding lag time does is it impacts the ability to convert services into cash, because delays in coding are ultimately going to delay billing. And we want to convert services to cash as quickly as possible because we still have to pay payroll. We still have to pay rent. And if things are hung up in coding and we can't bill, then our cash may not come in quickly enough to meet those obligations. Number 11, clean claim rate. This is the percentage of claims accepted and paid on the first submission without correction. The formula is the number of claims paid on the first submission divided by the number of total claims submitted, and then you take that result times 100. The data sources for this are clearinghouse acceptance reports and clearinghouse dashboards. The clean claim rate drives revenue cycle velocity. So a clean claim rate that is below 90% can signal upstream issues in coding or in eligibility or in data entry or all of the above. And one benchmark that is out there is a clean claim rate that is greater than 95%. Number 12, claim submission lag time. This is the average time from the date of service to the claim submission. And the formula for this is to take all of the different cases and take the claim submission date minus the date of service, and then we average that up across all of the different records. The data sources for this can be the EMR or clearinghouse reports. And when we're interpreting the claim submission lag time, a larger lag time is ultimately going to delay cash flow. And if it's long enough, it will actually create a timely filing denial risk. The benchmark is less than 2 to 3 days. Number 13, denial rates. This is the percentage of claims that are submitted that are denied by payers. And like the other denial rates that we looked at before, there are 2 ways to calculate this. The first is the number of denied claims divided by the number of total claims submitted. And then the second way is to take the denied claim dollars divided by the total claim dollars submitted. The data sources for this are clearinghouses, remittance advice, or EMR systems. It's important to stratify by reason because some of these have different root causes. So the actions that you're going to take are going to be different. So for example, within the overall denial rate, the front-end denials will have a different strategy. That might be re-education and intake. And coding denials might be provider education. So
This is the overall rate, but we can also zoom in on root causes. A benchmark for total denials is less than 5%. Number 14, accounts receivable aging distribution. This is the percentage of the total accounts receivable balance that sits in each of the aging buckets. By that, I mean the 0 to 30 days old bucket, the 31 to 60 days old bucket, the greater than 180 days bucket, or maybe greater than 365 days, etc. And the formula for this is that we take the dollars that are sitting in each of these aging buckets divided by the total accounts receivable balance, and that gives you the percentage that sits in that particular bucket. The data source for this is the EMR system and typically the accounts receivable aging report. The interpretation for this, we would normally stratify by payer to help pinpoint specific issues. It helps us identify the risk of timely filing and also the declining probability of collecting as balances age. And it can also be used for the finance and accounting department in reserve analysis. Number 15, days in accounts receivable. This is the number of days it takes on average to convert services into cash, and I have several YouTube videos on this subject. The formula is the numerator is your accounts receivable balance, and you add back the credit balances to that. And then you divide by the denominator, which is your average daily revenue. And what that is that is your revenue for a period of time divided by the number of days in that period of time. So let's say that you took a year of revenue, you would divide by 365 days to get that denominator. The data sources for this are the EMR system and specifically the accounts receivable aging report. And you might also use the general ledger for the revenue component. When we are interpreting the days in accounts receivable, lower is better because that means that it takes fewer days to get paid for the services you provide. So less days is better. A high days in AR can indicate numerous potential issues from follow-up productivity to upstream failures that are making it difficult to collect. Number 16, net collections percentage. This is the percentage of net collectible revenue that is actually collected. The formula for that is the payments received divided by the expected net revenue, and that gives us a percentage. The expected net revenue is what you are expecting to get paid based on your insurance contracts and your government fee schedules. So in other words, it's your charges minus your contractual allowances that make up that denominator. The data sources for this can be the EMR, payer contracts for the expected rates, and the general ledger. This is the gold standard revenue cycle efficiency metric, and a benchmark for this is to have a net collections percentage that is greater than 95 to 98%. Lower numbers here are going to suggest that we have avoidable write-offs that we could be working on fixing our processes to decrease those. Or it can also indicate under collection of patient responsibility and that we have an opportunity there to improve those practices. Number 17 is the cost to collect percentage. And this is the total revenue cycle operating costs expressed as a percentage of the cash collected. So the formula for this would be the total revenue cycle operating costs divided by the total cash collected for the same time period. Now, this is a contentious metric because what are we going to include in revenue cycle operating costs? So, for example, this is not just the cost of your staff, it can also be the cost of revenue cycle software or the cost of outsourcing contracts. For example, if you have a outsourced revenue cycle firm working legacy AR or augmenting your staff. So what gets included in costs sometimes is the subject of debate. What is more important is what this number looks like trending over time. So if you decide on a definition, as long as you're following that definition consistently, then you can see if that's improving or not. And some of the data sources for this can be the general ledger, payroll systems, or vendor invoices. If we have a high ratio in our cost to collect, it can be a signal of operational waste, under collection, inefficient staff or inefficient technology, maybe. And benchmarks can vary, but typically it can be less than 3 to 5%. Our final revenue cycle KPI is the bad debt percentage, which is the percentage of patient accounts receivable balances that are deemed uncollectible after we've exhausted all of our collections efforts. The formula for this is the patient balance bad debt write-offs divided by the patient revenue. And the data sources for this are the EMR system and the general ledger. High bad debt percentages can signal poor point of service collections or issues with estimating patient responsibility up front.
If you found this video helpful, in the description you can find a link to my free email list where you can download these slides and the formulas. You'll also get access to free training tools and templates. Also, please take a moment to hit like and subscribe so that you get notified whenever I put out a new video. And let me know what topics interest you in the comments.